Good afternoon, everyone, and welcome. Welcome to this very important session on health systems. My name is Shyam Bishen, and I head up the Center for Health and Healthcare at the World Economic Forum. I just wanted to take a couple of minutes to welcome you to this really significant, really important session, especially where we are now with regard to our health systems. We know that there are challenges, systemic challenges in the health systems, regardless of GDP. Obviously, bigger challenges in LMICs. So we want to make sure that we look at some transformative solutions. We have been talking about digital health, AI, and other things, but we want to make sure we discuss, as part of this conversation today, we discuss some of the transformative solutions. The idea is to look at overall system sustainability. We want to make sure we talk about closing the health equity gap. Those are some of the key things here. We know also, according to WHO report, that half of the world population doesn't have access to good health care services. How do we do that? How do we solve for that? So that's one of the key questions here. From our Center of Health and Healthcare perspective, we are working on some of these initiatives. We have initiatives on health equity. We are working on partnership for health system sustainability and resilience. We have value-based healthcare. All of those they make the part of the health system, and they try to improve the overall health system. So really interested in hearing our panelists' view on those. One last point I would make is this is the year, 2025 is the year of NCDs, non-communicable diseases, which we know is killing more people than infectious diseases, than communicable diseases now, even in LMICs, even in developing countries. So how do we respond to that? We had an earlier session today talking about health and prosperity through prevention, and there was already a call to set up something like global fund for NCDs. So I think this is good to see that this is on everybody's mind. This is on the leadership agenda, but would love to hear more from this panel here today. I know our time is limited, so I'm going to stop here. We are especially delighted to have the Minister of Health from South Africa, because South Africa is leading G20 presidency, so it's really important to have this on the agenda. But I would hand it over to our moderator, Honorable ex-Prime Minister of New Zealand, Helen Clark. Helen, it's over to you now, and I know we are in good hands with you now.
Thank you, Shyam, and thank you to all our panel for agreeing to come to discuss health beyond health care. And just quick introductions. We have the Honourable Minister of Health from South Africa down the far end of the panel here. Next to the Minister, we have Christoph Weber, President and CEO of Takeda. Next to Christoph, we have Victoria Lee, who's CEO and President of Fraser Health Authority in the British Columbia province of Canada. And then we have Winnie Byanyima, the Executive Director of UNAIDS. And then right next to me, Michel Desmarais, Chair of the Board of AstraZeneca. So a wide-based panel. I guess our topic focuses on the reality that 80% of health outcomes are determined beyond health systems. Health inequity, for example, flows from wider inequities within and between societies. So health systems, in a way, become the ambulances at the bottom of the cliff, trying to deal with the fallout from what society and the economy deliver. I was a health minister 35 years ago, and then as now, there was never enough money. The demands on the system were growing, driven at that time by the needs of the ageing society, the availability of ever more sophisticated treatments and products at a price. And of course, the expectation was that the system would deliver these and quickly. If we fast forward to 2025, added to the pressures that I felt all those years ago, there's the impacts of climate change on health and what it will mean for our health systems. The long tail of COVID-19 on our health system. Long COVID has left a legacy of ill health for many. The growing poverty and marginalisation, even in the highest income societies. And of course, the toll of deadly conflict in the many countries where that rages. So our health systems are ever more under pressure. And today's session, while short, is also wide-ranging across what needs to be done to ensure that in these challenging circumstances, our health systems can function well? How can they contribute to health equity, noting that it's driven largely from beyond the health system? And how do we get best value for money? So, my challenging task is to keep our panel more or less to time. We must finish at 2. We have a very hard stop. We have a broad question to each, which I'll ask for 2-minute answers on, and then specific questions to each panellist. And our broad question, and I'm going to begin with the Minister from South Africa, is in the context of the many health and societal challenges. Minister, what do you see as most needing to be done to improve our health systems and ensure more equitable outcomes?
Thank you very much, facilitator and fellow panelists, ladies and gentlemen. I thought, or rather when I was a medical student doing first year, there was a conference of WHO and UNICEF held in Alma Ata in the former Soviet Union, attended to by 164 countries, where I thought for the first time health was defined. And it clearly said it's not just the absence of disease or infirmity, but it's a state of good physical, mental, and social well-being. And I think the social well-being is what speaks to this topic, about your level of education, your income, your housing, your job, food security, and everything. I thought it was defining it. The second part, if I remember, I memorized it, by the way, when I was a first-year medical student. So it has got nothing to do with it. I, as a minister, we used to sing it, and one of my disappointments is what happened to Alma Ata, to primary health care, because we're running away from it. The second part of it, on their Article 2, they're saying the existing gross inequalities in the health status of people between developed and developing countries and within the borders of countries themselves is politically, economically, and socially unacceptable, and is of common concern to all. And I think that is one of the problems that we need to solve. In South Africa, more than any country, and I'm not exaggerating, our gross inequality is worse than in any country around the world when it comes to healthcare. Our Gini coefficient is the highest, and it keeps on growing. And if you want to see that, it's more embedded in health, because we have got two healthcare systems, one for the rich, the other for the poor. And so we are trying and battling to institute universal health coverage, which you call NHI. It's a big war. There are already 3 court cases to stop it by big business, right-wing organizations, even, unfortunately, doctors' groups who are saying we don't want this universal health coverage of yours, etc. So those are the issues that need to be solved if what we are discussing here is to become a reality. Thank you very much.
Thank you very much. And I recall as a young health minister being inspired by the Almaty Declaration, as you were as a student, so important words. Michelle, from the perspective of AstraZeneca and private sector, how would you respond to the question of how we can improve our health systems in this context?
Yeah, it's difficult to answer that in 2 minutes, Ellen, but I'll try at least to make 3 points. I think maybe starting with a statement that at the end, healthy populations are the foundation for prosperous communities and for strong economies. And so it starts probably by just considering health as a strategic asset, meaning that all the money we want to invest in there is an investment. It's not a spending that needs to be cut every year in order to fit the budget. So I think that's a very important point. Now, obviously, you look at health systems, you have already listed a number of the challenges that health systems have. I would add to that aging populations, 3 billion people living with chronic disease in the world nowadays, and also all the impacts of climate change that make vulnerable people even more vulnerable because of lack of access. So there's a huge challenge there. And obviously, I'm not here to say health systems should spend more because they don't have the money to that, but they for sure can spend smart. smarter. And that is where I think we have to all get together here to really think a bit long term what we can do to transform the way health systems are functioning, starting, for instance, by putting much more focus on prevention. If we think that nowadays in the OECD country, on average, 3% of a health budget is spent on prevention. As a result, more than half goes to hospitalization and to late treatment. And obviously, if we can change that, that would be a much smarter way to spend the money. Now, it would require bold decisions because that is not done in 2 or 3 years. So from the political leadership, we need to have bold political leaders that will have a vision that goes beyond the next electoral deadline, I would say. And to help them with that, we need from the private side to be ready to put together a private-public partnership to really try to help, coming with strategic help, with implementation help, and obviously as well with funding help. So that is the first point. The second is, I think we need to build trust. And building trust is really showing full transparency on the projects we are trying to put together as a partnership with clear goals. And I would give you one example, for instance, is the fact that today 120 countries have a national cancer plan, which is an excellent tool because it describes the accountability of each participant of the ecosystem. It puts clear targets with a clear timeline. Once you have that, you build trust and you can then be much more effective at getting new partners to join. And the third one that I would like to highlight as well is obviously health systems have to make also their own homework. They are marred with bureaucracy and dysfunctioning systems that don't communicate, hospitals that don't talk to each other. And obviously it's time there to invest in digital and data and in AI to make them more efficient. So bold actions, very collaborative. We can't do it alone. The private sector can't, the governments can't, but all together there is a chance.
Thank you, Michelle. Christoph from Takeda, do the AstraZeneca private sector's perspective words resonate with you?
Yes, they do, but I will add a few color. One, first, I think that we actually need to invest more in healthcare. And many countries today are aligning their healthcare budget to GDP, but population are not getting younger. Life expectancy still in many countries is expanding, and there is more innovation to finance. So when you do the math, it's quasi impossible to have the healthcare spend not growing faster than GDP naturally. Now, you can stop that, but it has consequences. The natural demand, just because of the demography, for example, is that healthcare is growing faster than GDP, which is a big issue because you have the issue of sustainable financing that has to be tackled. Now, on the other hand, you can gain a lot of efficiency in healthcare, and especially now with the innovation that happens, the data that exists in many healthcare systems, you can gain so much efficiency. When you think about healthcare, it was always designed to treat people once they are sick. We know that we are underinvesting in prevention. What we can do now is not only prevention, but also predictive healthcare. There is enough data, there is enough knowledge to actually know before the disease has progressed too much what type of issues people will face. And if we start to move into this notion of predictive healthcare, we will gain enormous efficiency and cost efficiency. There's been a lot of analysis done in that space, and it has been well described that we could save as much as 30% of healthcare costs if we tackle earlier the disease. And so I think that's really a very important component, but still there will be a need for sustainable financing.
Thank you, Christoph. Victoria, at Fraser Health, you're in the hard business of trying to deliver within a budget, so
yes, definitely.
Over to you.
An honor to be here, and I'll put my comparative health system perspective on for this, because by age 30, I worked or traveled to 84 countries looking at different health systems, aged a little bit since then, but I think a lot of the points that we're talking about really calls for radical transformation. There's been lots of incremental changes in our health system, but the sustainability that we're talking about is not possible with just little incrementalism. And I think I heard courageous leadership. I think sometimes a bit of bold and maybe even audacious and disruptive change might be required, and potentially also being really relentless in what that collective outcome looks like. Equity, resilience in our health systems. And I think one thing that we didn't touch on, we have all the epidemiological and cultural, all the changes. What we didn't touch on is also the public expectation is really changing. It's not that people are okay waiting for healthcare. It's not that people are okay not having access to their information. They want to see Amazon of services for healthcare where it's immediate, where it's right there and it's delivered. So I think we also need to think about that public expectation of it. And what I'm calling as radical transformation is really what you were talking about, both of you, around prevention. And we know that investments in prevention really make a big difference in terms of overall health outcomes, but also socioeconomically. I think McKinsey's study said around $18 trillion would be added into our GDP by 2040 if we actually did that. And at the same time, we only invest less than 5% across the board. So what does that transformation look like from sickness care to wellness care? For me, right now it's reactive. We would move to much more preventive and proactive care. Right now, it's quite hospital-based. We would move to much more primary community-based care. Right now, it's very siloed care. We'd move to much more integrated care. Right now, it is very much paternalistic. We would move to much more participatory at the individual, family, and community level. And I think you talked about precision. We would go into predictive precision, so individualized treatment and wellness initiatives instead of having one treatment for all. So I think all of those things would lead to radical transformation from turning our sickness system to wellness system, which is what we need for equitable outcomes and more resilient system.
Thanks, Victoria. Winnie, it's always an advantage to go last because you're reflecting on everything everyone else has said. How would you respond to that core question of the health systems sort of stepping up and ensuring more equitable outcomes?
Thank you, Helen. And it's such a pleasure to be with this. I've already heard so much that I agree with on this panel. But I want to go for equitable and affordable access. It's critical. You see, when effective HIV treatments were developed more than 20 years ago, they were not available and affordable for many years for most people in the world. During that time, 12 million people in Africa died while others were getting access to ARVs. Recently, during COVID, when rich countries, actually a handful of companies in rich countries hoarded COVID-19 vaccines, in the first year, 1.3 million people died, and those were preventable deaths. So I want to say AstraZeneca agreed to non-profit pricing for their Oxford University vaccine, and that was good because it was 97% funded publicly. So you did the right thing. But a handful of companies didn't. So what needs to happen? For me, it is to ensure that equitable and affordable access for everyone in the world, irrespective of where you are born. That needs to be built into national health and trade systems. You need to put it in both. Africa imports 70% of its pharmaceuticals. 70% is imported. I hope that now as we wait for the pandemic's accord, which you prepared so well for, Helen, but which countries have failed to step up and agree to, I hope that there in that accord, and also with the G20, who agreed last year to a coalition for regional production of medicines, that these are global processes that will lead to fixing this problem of equitable access. We need to fix that. That, for me, is what I would fight on. And then the second point is that COVID showed how much we need resilient, properly funded health systems. You know, in 2021, again, African Union has an agreement between all the member states to allocate at least 15% of their budgets in health. Yes, that's an agreement of all the member states. But in 2021, only 2 countries out of 54 were doing that, and that's South Africa and Cape Verde. Reason? Because all of them, nearly all of them, 34 out of 54 countries today are paying more towards debt servicing than to their health budgets. So we must solve this skewed international financial system that doesn't allow these countries to collect enough taxes, to have enough money to invest in health. So I agree with those who talked about the investment in health being too low, and that the only way to solve this is also to solve tax dodging, to solve interest rates that are unfair to the developing countries and all of that. So I think there are many things outside the health system that need to be fixed.
Thank you, Winnie. We're going to come back to Minister Motsoaledi. You have embarked on a big healthcare reform, and you mentioned in your opening comments that you've inherited 2 health systems, and your aim is moving towards universal health coverage. Would you like to tell the audience a little bit more about the challenge and what your hopes for the reformed system are?
Yeah. The issue of universal health coverage, which many countries take for granted, is a big issue in South Africa. As I said, I'll repeat again. We are running 2 healthcare systems in my country. One is as good as you can find anywhere in Europe, and this is not an exaggeration. That's private healthcare for the well-to-do. Maybe when I use the word rich, it looks like I'm talking about millionaires. For the well-to-do. The second is like any other healthcare system on the African continent, not equipped in terms of human resources and everything else. And the problem is that in South Africa, we're already spending a lot on healthcare. We are on 8.5% of the GDP on health, which is very high. There are not many countries that are at that level. I know Europe averages 9. Now, the problem in South Africa is that with all that money, and I'm at pains to mention that you can't say money is ever enough. There's no enough money anyway, as you have already said. But the amount of money we spend on healthcare, not many countries can reach that. But the manner in which it's divided, talking about gross inequalities again, 51% of it goes to only 14% of the population. And the remaining 49 has to serve 86% of the population. I don't think any other country on the globe can be described in those terms. Unfortunately, that's where we are now. The only way to change that is universal health coverage, to come with equity in healthcare and divide this money in an equitable manner. We won't really need any extra money because, as I said, you never have enough money elsewhere. So it's not a surprise that now, because of our G20 presidency, we have got 5 priorities during our G20 presidency. Number 1 is universal health coverage based on primary health care. Yes, that you have got to make sure that there's promotion of health, there's prevention of diseases, even before you start curing diseases, because many of our countries at the moment are married to a curative healthcare system, which you know is very expensive and does not produce results. So our universal health coverage, which you call NHI, National Health Insurance, is going to be based on primary health care. In this regard, facilitator, we're already looking forward because we're scared. The world is now faced with an epidemiological switch from communicable to non-communicable disease. Well, countries in the north have already entered that long ago. Countries in the south are still in the middle. South Africa is in the middle. Many countries in the south are still at the level of communicable diseases. We are somewhere in the middle as South Africa, but about to switch over. And for that reason, we have already started preparations long ago. Number one, we have done salt reduction in a way I don't think many countries have done, to reduce salt in 6 foodstuffs, including bread, chicken, spices, etc. We have reached that with industry. Number two, we have introduced a sugar tax. People believe we want the money. We don't want the money. We just want them to eat less sugar. And that's why there is tax. And we are now strengthening our anti-tobacco legislation. We are one of the first countries in the starting blocks. And we have been overtaken. We are strengthening that because we want less smoking, much, much less smoking in the country. If possible, zero smoking, if we could ever reach that. I know it's not possible. But we are fighting all those because we are preparing for the time when our communicable diseases are past history or are just sporadically there, and we are in the helm of communicable disease. Now, my question, I'm working under the assumption that there's no country on earth that will fund another to fight non-communicable disease, except health system strengthening. We are getting a lot of money from PEPFAR, which unfortunately is being threatened. I'm sure it will be a topic for another day. And Global Fund. We are getting that money to buy ARVs, etc. And I'm working under the assumption that nobody can give me money to buy antihypertensive, and it's not going to happen. Now I'm hearing that there might be Global Fund for non-communicable diseases. I don't know how it will work, but I'm telling people that if we don't have universal health coverage, we'll be in trouble because there won't be a PEPFAR or a Global Fund for non-communicable disease. Every country will be on its own and they must do it for themselves.
Yeah, it's true. Yeah.
Thank you.
Thank you, Minister. And I think what you're describing is a need to equip your healthcare system to be able to take on fighting that burden of disease as you switch from communicable to non-communicable. This is extremely interesting. Coming back to Michelle, would you like to elaborate on where you see the private sector, public sector partnerships really working to help strengthen what we do?
Yeah, for sure. And because, as I said in my introduction, I think the PPPs are absolutely needed if we want to try to solve this issue. And I think they can be used both at strategic level and at implementation level. And obviously, if I talk strategic level, I want to talk 2 minutes about the partnership that we have founded together with the WEF and with the London School of Economics, which is a PHSSR, that stands for Partnership for Health System Sustainability and Resilience, where we are basically sponsoring countries' studies of making a full assessment of the situation of a health system and then issuing a number of evidence-based recommendations. We then convey all the actors of the ecosystem around the table and really try to come to effective solutions. And I could give many examples here at the time of countries where we have done that. A lot is about prevention, about early detection, but also about better use of digital and data and all kind of other recommendations in terms of administration that can happen too. We're also now extending that to NCDs, and in fact we're going to soon publish the PHSR report about NCDs, which I would really encourage you to read because, you know, the facts are so impressive. If you see, for instance, that between 2010 and 2030, we estimate that the cost of NCDs to the planet will be $47 trillion, which is 2 times the GDP of the US. When you hear this kind of number, you say, well, you know, maybe there should be some money available to try to tackle this. Also knowing that 80% of mortality from NCDs could be saved, actually, if properly addressed on time. So that is one example on the strategic level. And then you have to get down to the implementation too. And that is where we as private players also go to several countries and try to implement solutions. I can think, for instance, in Canada, the province of Ontario, where together with the government and a lot of actors of the ecosystem, we have been trying to optimize the patient pathways for people who suffer from COPD, earlier screening, quicker follow-up, much better access for people who can't afford normally to do it. And so that obviously takes care not only of the patient, but also of the cost and also of the sustainability, because patients will have to be much less in hospital or go into the hospital to happen. In Malaysia, for instance, we work with the government to have a whole lung health awareness program to really go into the population and teach them about the danger of bad lung health. This has resulted, for instance, nowadays into 65,000 screenings that happen, and we have already detected more than 2,500 cases of people we didn't know were sick, but already pretty much at an advanced stage. So all this kind of implementation partnership can really help a lot. The last one, rare disease, a huge issue also in terms of health equity, because these are treatments that are extremely expensive and that obviously the most vulnerable, again, can't afford. There's so much you can do that in screening, and nowadays we work already with a number of countries to help with proper gene sequencing to do screenings of newborn babies and really try to tackle this disease when it is still time, which is obviously a much better outcome for the patient, but also a lot of cost saving for the system. And the third point I would like to do is also, there's a lot of initiative, especially for multilateral organizations, and it is our role as a private player to support that. For instance, WHA in May will vote a number of resolutions. There's one, for instance, on lung health, another one on CKD, another one on rare disease. We are, and I'm doing that a lot here in Davos, talking to as many governments as we can to support this initiative and make sure it comes in place, because once resolutions like this are being voted, it helps countries to prioritize, to give resources to it, and to start defining outcomes that can help tackle the problem. So these are three examples of what we can do together, and I hope also we'll put you on the screen at the end a scan for being able to read this PHSSA report. We are always looking for new partners, so if you're interested, please let us know.
Thank you so much, Michelle. Winnie, coming to you, the populations UNAIDS serves are often among the most marginalised and the most discriminated against in the world. So what is the role of the health systems in trying to overcome the barriers to access and treatment that these populations face?
Thank you, Helen. Yes, the people we serve are on the margins of society. People living with HIV are stigmatized everywhere in the world. No country has no stigma. And then those who are at risk are also stigmatized and criminalized. It's gay men, it's men who have sex with men, it's sex workers, it's trans women. It's, now I hear that in one famous country, trans women don't have a status, you see. So the way these people can be reached is when you have a system that takes treatment and care out of the hospital into the community. They have their dignity if they are served by their peers. So we emphasize community-led services, community-led monitoring, anchoring the service, and so much of what happens in the hospital doesn't have to happen there. You just have to change the relationship between patients and health workers. So much, HIV has proved that so much can be taken out of the hospital and clinics and placed in communities for communities themselves to serve their people. So that's so important. This is about human rights. It's about the rights of people to their dignity. And I think that this has huge cost implication. You really reduce costs, reduce lengths of times. Let me give you an example with girls. Girls in Africa are the most at risk of getting HIV. Did you know that? In the age category of between 15 and 19, those adolescents, 6 out of 7 new infections are girls. That's how high their risk is. How do you reach them? You can't say you must report to a clinic and get your prevention. No, you need to find them in their youth clubs. You need to find them maybe even at home, in their communities, for them to have something that will prevent them from being infected. So you see the need for taking healthcare out of the institution of the hospital. Secondly, the way the health system is funded, and here I'm going to disagree with the best example of COVID treatment, AstraZeneca. I'm going to disagree about private crowding, in this whole thing of crowding private money to get financing for health. This will never guarantee the healthcare right, the right to health for everybody. I don't believe that. You will always have those who are not served. Bloomberg issued a report last week. It is shocking. You need to see it. And it's a research about the World Bank's lending to private hospitals. Many of our countries, in the low-income countries, the advice from the bank is that bring in private money. You will never have enough to serve your people. This report is shocking. It tells you, and it's about my country, Uganda, Philippines, and it tells you stories of people who are held prisoner in prisons, in hospitals, because they cannot pay the bill. It tells of stories of babies refused emergency treatment because they cannot put down a deposit before they are served. This is the kind of thing you get when you lend to private sector to seek profits in context of massive poverty. So I'm quite opposed to this miracle idea that the private sector will serve everybody. The people I work for will never have the money to pay, will never even have a job that gives them an insurance to pay. They will always need a public health system that's free at the point of use. And let me say this, it's possible. This idea of private money and private health has come more recently. We still have countries that prove that you can fully fund a public healthcare system that's based on prevention and that affords good treatment for everybody. Take Thailand. Thailand has a GDP much, much less than many European and the United States of America, but has a public funded health system that integrates services, good services of prevention and treatment for people living with HIV. So we need to, I went to Cuba last year, Helen. When you talk about Cuba, people think you are a communist. But the truth is that they have a health system superior to many industrialized countries based on family care. I found an NGO training, and it does these regular trainings, health workers, doctors and nurses on how to address, how to deal with stigma. And there were these trans women, gay men, facilitating the workshop, showing these professionals how to address their unconscious bias against these groups of people. A human rights-based approach is what we need if everybody's get what they need. And you can only do that when you bring communities to work hand in hand with the health professionals. I saw that in Cuba. I was so impressed. So to end, the way we fund the health system is important. Let us have public health care systems, and let us have the option for those who are rich. Like me in my country, I'm rich, but in the world, I'm not. But in my Ugandan context, I'm very highly paid. I can go for private health there. But let the ordinary person benefit from a healthcare system that's publicly funded, and it is possible. And it must be human rights based, it must work with communities, it must focus on people delivering for themselves healthcare. Thank you.
Thank you, Winnie. Victoria, Fraser Health is a signatory of the WEF's Zero Health Gaps Pledge,
Yes.
which has been signed by more than 100 CEOs. Why did you sign it? And how is it guiding the actions your organisation's taking to address the gaps caused by inequities and inequalities?
Thank you, Helen. And I think it's such an important point because I've the privilege of serving as CEO president, as you mentioned, for Fraser Health. We cover 20 municipalities. And one of the things that we found when we looked at the data was that even in a small geographical region, 2-hour drive, there was 8.6 years in life expectancy gap. Not as stark as the one that was shared by the minister when you're looking at global context, but for a high-income country and looking at that 80% of health outcomes are actually outside of healthcare, we really felt that we need to reduce that gap. It's unjust, it's unfair. We need to make sure that we're providing services in a connected way that actually reduces that gap. And we developed a project called Hope to Health and Wellness, and that really brought in the usual players that we have in health, but also unusual suspects in terms of local governments, businesses, NGOs, academia, all coming together to look at, so this is what we're seeing, what are the priorities that we need to set, and really locally community-driven solutions and strategies in reducing that gap. And some of them targeted health services, like mental health services. Some of them looked at prevention, like physical activity, and looking at beyond just physical activity of movement, but what does built environment look like in that physical activity? And then some of them actually looked at transportation, which is outside of healthcare, but again, is that determinant of health that actually allows for people to go to health services, go to their jobs and all those things. So bring it all together, the community came with the strategies to reduce that gap, and it's a community accountable service where people are looking at governing that. I must say, we're still on our way to get there, but I had this privilege of joining Canada-UK colloquium that recently looked at one of the marmot places in Wales, and I visited there to look at one of the places, and marmot places are 50 in the UK, and I believe scaling to Italy as well. That's very much equity-based, bringing, again, partners together at the table to across at the areas of early childhood development, education, housing, governance, and putting equity into all policies and programs and initiatives. And some place like Coventry, where they've implemented these programs, they've seen 20% reduction in vulnerability and the disparities that we see in health equity. So I think there are, solutions like that, whether it's in Canada, in my region, or in the UK. And I've got another example as a board member for CARE, which is a humanitarian organization. I'm sure when you worked with them as well. And in Kenya and Tanzania and Zambia, they work with young women. It's called She Soars program. And again, it's not just in health. There's health education, sexual reproductive health as an emphasis and focus, but there's job training, there's financial literacy. Young people came together to actually, again, find what do we need to do differently to reduce that gap. And these were young people that were out of school. 17,000 sessions held, young girls, young boys, thousands of people that have been trained in health and otherwise, and it's making a difference. So I think overall, the messages are participatory, there's localized solutions, there's unusual suspects sometimes that are brought to the table beyond health, and then having localized solutions that are actually monitored, accountable. And I think the big part of it, which we're doing in Fraser through digital front door and digital twin, but how do we scale and looking at technology at hand as well?
Thank you. Christoph, you're going to get pretty much the last word. What's the key change you're going to advocate?
Well, first I will finish by saying that we have good reason to be optimistic about how healthcare can improve in the future. In many countries, there is political willingness to create better healthcare systems, but we are also at the crossroad where science is really helping to identify earlier what will happen. And, when you build your healthcare systems, you need to think about data. We have never, in fact, leveraged healthcare data a lot or enough. But we can now really leverage healthcare data. And when we talk about non-communicable disease, the diagnosis is always very, very late. Often 10 years, 15 years after the disease actually started. And that's why it's so expensive, because you are immediately into a curative mode. We have now science and data to be able to to diagnose way earlier. And that's why I'm talking about predictive. Prevention is exercise, eat well, sleep well. Predictive is you will have a cancer, or you have a very early stage cancer that we can detect in a blood sample or a DNA fragment or other element of data, and you can tackle that earlier. So I think that's a good reason to be optimistic, because the efficiency that we will see will be extraordinary. So that combined with political willingness to have equitable healthcare systems, still sufficient funding, let me very optimistic for the future.
It's great to end on an optimistic note, and I think what's really come through all the contributions is the importance of prevention and prediction. I'm going to add that into the mantra now. The primary health care, the community-led services, the participatory, and then this commitment to equity and ensuring that everybody can have a stake in the health system and expect to get the services that they need. So thanks everyone for a brilliant panel.
Thank you. You through the panel when you